the idea of exertional leg pain for you today, and hopefully answer some questions at the end. So without further ado, I have no disclosures. My opinions are my own. So my objectives today are to define the concept of exertional leg pain versus other types of leg pain that may be associated with activity, and then go through the differential diagnosis for exertional leg pain and break it down by systems. And so talk about the different causes within each system, and talk about a way to do your evaluation and look at it systematically. I'll review as we go some of the recent evidence for some of the common causes of exertional leg pain, and then talk about some ways to think of exertional leg pain outside of just a single system paradigm, but how the systems may interact with each other, and there's some interplay there. So I'm going to start with some cases. So I've got 4 cases, and these are all patients that I've seen in the last couple of years. And so we'll go through each one briefly, and then we'll circle back to these at the end. So the first one is a 17-year-old male athlete, plays multiple sports, including football, basketball, lacrosse. He presented with exertional leg pain that had been going off and on for about a year and a half, the left worse than the right. Says basketball is the worst, but when he does repeated sprints in football or lacrosse, he gets this pain as well, and he just can't push through it. If he can rest, it gets better. Occasionally, if he has a really bad episode, there'll be some soreness afterwards. And he has some mild plantar foot paresthesia and some dorsiflexion weakness, but that doesn't linger. It goes away as soon as the pain resolves. The second case is a 17-year-old female athlete. She's also a multi-sport athlete in soccer and cross country. She has exertional leg pain, but the right is worse than the left. The pain started on the right. Initially, it was pain at the end of her runs, especially longer runs. But more recently, she started having pain earlier on in the runs as well, and now starting to have some pain with soccer, whereas it didn't start, or when it started, it didn't bother her to play soccer on it. Rest usually makes it better, but most recently, rest isn't really helping as much as it was before. She doesn't have any neurologic symptoms, just the pain in the leg. Our third case is a 26-year-old male. This is Army infantry. He has exertional leg pain with walking, running. Rucking is the thing that he says is the worst, especially if he's got quite a bit of weight on his back. So he starts to develop some aching in the legs. This started about a year ago. It's been progressive in both legs the same. Gets some foot paresthesias, describes the whole foot. Top and the bottom goes numb. And if it gets bad, he gets some foot drop where he can't pick his toes up. So initially he would get better with rest, but now rest isn't helping as much, and his symptoms are happening earlier. He gets symptoms almost immediately when he starts walking or running, and it's limiting at his job. And then the fourth case is a 26-year-old female. She was Army infantry, but she's recently switched over to doing a job with cybersecurity because of this pain that she's experiencing. So progressive pain. She also has weakness and paresthesia in both legs. She was actually diagnosed with chronic exertional compartment syndrome by history and exam. They didn't do any compartment testing, which we'll talk about as we go, and ended up having bilateral fasciotomy, but got no symptom relief from that. As soon as she started doing her rehabilitation after the fasciotomy, her symptoms started coming back. She has had the fasciotomies of the anterior and the lateral compartments, and now just having that persistent exertional lateral leg pain and dorsal foot paresthesias. So we'll keep these 4 cases in mind, and I hope you've developed a little bit of a differential for what you think might be going on with each of them. And I'll circle back and I'll let you know where we're at with each of those. But we'll talk about how the lecture today plays into their evaluation. So let's define first what does leg mean when we're talking about leg pain. We're talking about anything distal to the knee joint and proximal to the talocrural joint. And we're going to leave major tendons out of this. So patella tendon, Achilles tendon, posterior tibial, peroneal tendinopathies. We're going to leave that out. Tendinopathies, while they may cause symptoms with exertion, do not typically fall into what we would define as exertional pain, which I will define next. So what is exertion? So this guy is definitely exerting. I'm going to use the word stuff because that's what the patients always tell me. They say, it hurts while I'm doing stuff. So exertional leg pain, they'll have pain while they're doing whatever their activity is. And typically the pain will increase as they do more of whatever that activity is. And doing more activity equals more pain, and doing less activity equals less pain. And there's some crossover. It's not a hard rule that, that they won't have pain at rest, or that they'll never have relief of pain as they warm up. There is some crossover, and we'll talk about those exceptions. But generally, we're talking about pain that increases with activity, both within a single bout and with repeated bouts of exercise over time. So we're going to break down the differential diagnosis for exertional leg pain into these three categories: musculoskeletal, vascular, and neurologic. And as you can see from that picture, and we all know, there's a lot going on in the lower leg. There are a lot of structures that are closely tied together. So we'll start with musculoskeletal. So the conditions on the left of the screen are sort of the traditional exertional leg pain conditions. So chronic exertional compartment syndrome, medial tibial stress syndrome, and bone stress injuries. And then the conditions on the right are common mimickers that can appear as some of these other exertional leg pain conditions, but aren't necessarily exertional in and of themselves. I already talked about tendinopathy. The tendinopathies tend to get better with warm-up. So they may have some pain initially on exercise, and then it tends to abate as they go, and then may come back toward an end of a bout of exercise, and then have soreness afterward. And that's the differentiation with exertional leg pain, is it doesn't tend to get better once they stop exercising. It may actually be more painful once they cool down a little bit. Some other things there, but we'll jump right into it. And first I want to talk about medial tibial stress syndrome. And this is one of those conditions that gets thrown into the wastebasket of shin splints. So when we say shin splints, nobody really knows what that means exactly, but medial tibial stress syndrome may be something that falls into that. So this is posterior medial tibial pain, usually in the middle to the distal third. You can see in this picture on the right, the people will point right to that medial border of the tibia and hurt right along the edge of the bone. We don't know the exact cause of this, but it is pretty clearly associated with some low bone density. Whether bone density is a risk factor for medial tibial stress syndrome, or whether it's something that happens afterward, we don't really know, but there is an association. And it's usually in people that are doing some activity with an unaccustomed load. So a new activity, new intensity, new shoes, new surface, something, they've changed something and they're not used to the load that they're now experiencing. Pain typically subsides during activity with medial tibial stress syndrome. So this is one exception to that rule that I talked about with exertion, that oftentimes people will say, once I warm up, it gets a little better, and then may come back if I go too hard or too long. And again, usually they'll have that exquisite but diffuse tenderness to palpation along that medial tibial border that just doesn't localize very well. I won't get too much into the treatment of this just in the interest of time, but as I said, it's due to unaccustomed load. So the treatment for this is usually a load management strategy. So relative rest, backing off the activity that's causing pain, cross-training with something else, working on their biomechanics, maybe working with flexibility if they have inhibited range of motion at joints in the ankle, the knee, or the hip, but trying to do load management strategies with them. And these people will usually get better. Rarely this will advance to a bone stress injury. That's all I'm really going to say about this one for now. I'm going to move on to bone stress injury. So since we're talking about leg pain, we're going to stick mostly to tibial bone stress injuries, and we'll talk a little bit about fibular bone stress injuries as well. I think we've all had a lot of experience or lectures, certainly, talking about bone stress injury within the military, because it is a population that gets a lot of bone stress injury, especially in basic training. And thinking about stress fractures in long bones, there's always a concave and a convex surface with the long bones. And so tension stress fractures will happen on that concave or convex surface, excuse me, where when the bone bends a little bit, there's tension on that convex side. And then there's compression on the concave side when they bend. So that's one way to think about bone stress injuries is are they tension or compression? Tension usually portends a worse outcome, and compression side usually heal better just because of the loads. The stress injuries can happen in cortical bone or cancellous bone. The cancellous bone is more toward the metaphysis at the ends of the bones, and get more cortical stress fractures within the diaphysis of the shaft of the bone. You can think about bone stress injuries in terms of fatigue or insufficiency type injury. So fatigue is a normal bone that's submitted to abnormal stress. And then insufficiency fractures are usually abnormal bone that may have injury with normal stress on the bone. So we have to think about what the patient's risk factors are for stress injury. So we'll get to the risk factors here in a minute, but diagnosis of tibial bone stress injury, usually the sort of classic imaging modalities that we use are X-ray, bone scintigraphy, and MRI. CT, not very often. X-ray has low sensitivity, but it's very specific. So that picture on the right, you can see the dreaded black line and a little bit of periosteal elevation. So if you see that on an X-ray, you've got your diagnosis and you don't have to do any more imaging. So X-ray is usually recommended as the first, whether you're going to get additional imaging or not with the first study. Bone scintigraphy classically was something that we got a lot of, but that's fallen out of favor because it's very sensitive. If you get a negative test, there's probably not a bone stress injury there, but it's very non-specific, and it's not very helpful in guiding treatment. And you can get positive bone scans well after a bone stress injury is healing. So MRI has become the gold standard typically for diagnosis of bone stress injury. It's highly sensitive and specific. And there are grade scales such as the Fredrickson grading scale that can be used depending on whether you see edema in the periosteum, edema in the bone marrow on the T2 series that you can use to guide treatment for bone stress injuries. But I want to focus a little bit today on some studies that have recently come out. These are from the Air Force Basic Training down at Lackland Air Force Base. And Dr. Nate Nye, who many of you probably know, who's with the fellowship, he was the lead author on these studies down at Lackland when he was there. And two studies from 2016 and 2020. At basic training, they spend a lot of money evaluating bone stress injuries, and there's a lot of time lost. And what they wanted to do was develop a clinical prediction rule and an algorithm for evaluation of these injuries that would limit unnecessary testing, basically, and save some money on sending a lot of people for evaluation when maybe it wasn't needed. And they came up with a bone stress injury score, and we'll get into how they score that, but they came to this score of 4, so greater than or equal to 4 with at least one physical exam finding, then they should do a complete evaluation. And if there was a high negative predictive value if they were below this threshold. And so they were able to save a lot of testing and a lot of time lost by not having to send people for a full evaluation. So the bone stress injury score had 3 categories. There was risk factors and symptoms, and these should look familiar to people. I think we've talked about these and we learn about these. These ones that I've highlighted in red are going to pop up again because these floated to the top as maybe the most important factors. But you can see a lot of in the risk factors, low fitness, metabolic deficiencies, and other things that put patients at risk. And this PAES, even though it's a physical exam finding, it's kind of a fixed finding. So they put that under a risk factor. And then symptoms. So again, these probably look familiar to most of us. And then exam findings. And again, that one in red is going to float to the top here in a minute. Some of these, like pain with hip internal rotation, the fulcrum test, are more specific to hip injury. And so we won't talk too much about those today. But again, that focal bony tenderness is important on physical exam. So that was part of their 2016 study. They came up with an algorithm and that bone stress injury score. And then they validated that algorithm with some additional research. So they came up with in 2020 this optimized prediction rule. And I just want to highlight that this bone stress injury, or this applies to bone stress injuries that are at or distal to the femoral condyles only. So this doesn't necessarily apply to stress fractures that we might see at the hip or in the upper extremities, or even some of them in the foot. But they, using the variables that we already discussed, they did the statistical magic that people do, and they came up with these 4 variables: bony tenderness, a history of bone stress injury, a pes cavus foot, and increased run walk volume as the 4 variables that were the most predictive. And they could use those 4 variables, and using those 4, they came up with this score of greater than or equal to 3 deserves an additional workup for bone stress injury. But if they came in, had a score less than 3, it was very sensitive and had a very high negative predictive value that they didn't need to do additional workup for bone stress injury. They could treat it as whatever else was highest on the differential and do their evaluation down that pathway. And significantly, they showed that a lack of bony tenderness had a similar negative predictive value as the score. So if they did not have focal bony tenderness, they could defer unnecessary bone stress evaluation and unnecessary time lost and treat it as whatever else might be highest on the differential. So let's look quickly. I know this is probably going to be difficult to see, especially if you're watching on your phone, but I'll break this down into smaller pieces. But this is the algorithm that they used, that they came up with from this study. So we'll look at this in a little more detail. So the first thing, again, is this bony tenderness. That's your first decision point. Do they have bony tenderness? And if the answer is no, then consider imaging and treatment according to the other differential, the other things that are that they might have symptoms of, and then follow up in a couple of weeks if they're continuing to have pain despite appropriate treatment. If they do have bony tenderness, well, then this should look familiar a little bit. Do the evaluation for bone stress injuries, get an x-ray, start limiting their activity, their impact, make them non-weight bearing if they're still having pain or if it's a high risk stress injury. Consider doing an evaluation around their risk factors. So get a vitamin D, a CBC, check for anemia with an iron ferritin panel, and then avoid NSAIDs. Let's go down to the next section. So if you do the evaluation again and their imaging comes back positive for bone stress injury, well, then you can move over here and continue to do the treatment for bone stress injury. If they don't have imaging positive for bone stress injury, then you can continue your evaluation as you otherwise would. But again, using that score as a cutoff, you can save a lot of people from going down this, this path of getting a lot of imaging, MRI, a lot of time lost that was unnecessary. And that in the military setting makes a big difference, being able to get people through basic training. If people get held back or held over, chances are they may not make it and they may end up washing out, the higher risk of washing out of basic training in the end. So being able to keep people on schedule and keep them moving is a good thing. And I think this, applies best in a military setting, but I think the algorithm applies with athletes or in any other setting as well, where we can treat without having to do a lot of unnecessary imaging. So let's shift gears now from bone stress injury to chronic exertional compartment syndrome. This is something that we see a lot of, at least in suspicion for this. So chronic exertion compartment syndrome is elevated pressures, either subfascial or intramuscular, within the lower leg compartments. And we'll look at a picture of those in just a minute. And the question is, does that elevated pressure cause decreased perfusion of the muscles or muscular ischemia? That's kind of the idea, is that pressure will result in decreased perfusion, but we don't really have evidence of hypoxic injury or decreased perfusion. We've never really been able to prove that. We definitely see that with acute compartment syndrome, but put this in red here, chronic exertional compartment syndrome and acute compartment syndrome are not the same thing and don't necessarily need to be treated in the same way because the result is not the same. Again, we don't see that hypoxic or muscular ischemia that causes injury to the muscular tissue like we see with acute compartment syndrome. So what is the cause of the elevated pressure? We can do pressure testing and know that the elevated pressure is there. Is that a causal thing or just an association? So theories or ideas for what might cause that, or you might get muscular hypertrophy that's causing elevated pressures. Maybe there's reduced compartment volume from injury or from myofascial stiffness secondary to some metabolic things like diabetes or other metabolic kind of syndromes. Maybe there's shortened period of muscle relaxation in those muscles for whatever reason, neuromuscular kind of things that maybe that shortened relaxation causes a prolonged elevated pressure between muscle contractions. But we don't really know and haven't been able to really prove it. But you see on the right this schematic of the compartments in the lower leg. And you can see that especially in the anterior, lateral, and the deep posterior compartments, there's a lot of high value things in there, arteries and nerves that supply the lower leg and the foot. So things that we want to take care of and keep functioning for the patient so that they can function. So go to the next. So compartment pressure testing has kind of been the gold standard for determining whether someone has chronic exertional compartment syndrome. But what we found, and many of you probably know Dr. Wes Zimmerman he's in the Dutch military and has done a lot of work at the university here and with our fellowship. And he did a study where he took several hundred patients and did compartment pressure testing on them and also had them rate their pain scale. And there was no association between pain and measured pressures, meaning that there were a lot of patients who had very low pressures but exquisite pain, and some patients that had very high pressures but really didn't have much pain, and there was no relationship to predict. So just because a patient has a lot of symptoms does not necessarily mean that their pressure will be elevated, and vice versa. But still, fasciotomy, or releasing those compartments, has been the treatment gold standard for chronic exertional compartment syndrome. And the Pedowitz criteria is kind of the gold standard for that we use. So a pre-exercise pressure of greater than 15, greater than 31 minute post-exercise, and greater than 25 minutes post-exercise. But even these numbers are not set in stone. There's some question of how valid these numbers are. Some people have suggested it should be 14, 35, and 25, but the 15, 30, 20 is easy enough to remember. Or excuse me, 14, 35, and 24. So how do we evaluate this beyond just doing compartment pressure testing? I think a prudent evaluation, if you suspect CECS, should at least include an X-ray to rule out fractures, rule out other osseous lesions, osteochondromas, or bone tumors, or other things that are in the differential. I think probably most of them should get an MRI, and we'll talk more about what the MRI's role is with some other things, but the MRI can rule out bone stress injury, and it can look for other anatomic anomalies that might be mimicking chronic exertional compartment syndrome. If you have the capability, doing ultrasounds to evaluate for other causes of exertional leg pain. And I put in here that CECS likes company. There's some question that CECS may not be something that's always or very often found in isolation. We'll talk more in a minute about some of the evidence that shows that CECS probably travels with other things, and what's really the primary driver of the patient's symptoms may be something that we should question. So there's this idea that's been proposed by a number of people, biomechanical overload syndrome as a differential for chronic exertional compartment syndrome. And the idea behind this is that when you heel strike, you increase the anterior tibialis activity exponentially. So if your running gait pattern is a heel strike pattern, you'll have a lot of anterior tibialis activity. Also, just walking, excuse me, if you have increased load or increased speed of walking and you're a heavy heel striker, that puts a lot of stress on the anterior tibialis. In the military, that's prevalent because we do so much walking with load, so rucking with a heavy pack and your full body armor and all the things that we that we do to load people down. And then we throw them in combat boots. And these ones aren't too bad here on the right. But you can see bulky, heavy boots with a big, thick sole. And that changes the lever arm. It changes the physics involved in your walking and your running gait, and puts the tibialis anterior to disadvantage. So this is some of my own personal artwork. I didn't sign it, but the orange line is the foot and the lower leg, and those red lines, you can see the calf muscles, the Achilles tendon, and the anterior tibialis. And the center of mass lies somewhere under the foot, and then a center of rotation somewhere kind of in the middle of the talus, probably. But if you tip the leg back and land on the heel, you can see, you don't have to measure this, but just that the lever arm of the anterior tibialis is very short compared to the lever arm from the back of your heel to the center of rotation. And so the anterior tibialis is at a big mechanical disadvantage. And then if you take a big heavy boot and put a big heavy thick sole on the bottom of the foot, you increase that mechanical disadvantage even more. And so you put a lot of stress on the anterior tibialis in that anterior compartment. So to support the idea that maybe CECS is a mechanical kind of thing, let's talk about some treatments that aren't called fasciotomy. So some other things that we found that work. And this study by Debal et al. In 2012 up at West Point, they took some, these were physical therapists. They took some patients that were scheduled for surgery or had been advised to have surgery for chronic exertional compartment syndrome. So they took 10 of these patients and they did a 6-week gait training program with them where they trained them to run with a more 4-foot gait pattern. And then followed them over the course of a year and immediately after the training. And they found that they had reduced compartment pressures, they had reduced symptoms, they were able to run longer without the pain. And that benefit was sustained over the course of a year. And none of the 10 patients ended up needing surgery during the course of the study. And that's been repeated by a number of different people that they found that gait retraining is a good treatment for chronic exertional compartment syndrome, especially anterior compartment syndrome. And making a more 4-foot running pattern can help people not need to go to surgery. There's a couple of case series about Botox, and we've got some ongoing studies that we're trying to get going here locally to really take a better look at this. But using Botox into the anterior and the lateral compartments can decrease compartment pressures. Patients did have decreased strength after Botox, but it didn't seem to affect their function. They were still very functional. So again, the idea there, we don't have to release the compartments to reduce the pressure, and the Botox may have a more neurologic effect than a actual mechanical or just purely pressure effect too. We're not sure, but in support of that idea, there's some unpublished preliminary data that was Dr. Butler and some other people here locally have been doing, where they were using lidocaine injections, and patients were having reduced symptoms just from the lidocaine in some patients. And the question is, would that really reduce pressure? We don't know. But it did seem to predict whether they would have success with a Botox injection if lidocaine changed their pressure or changed their symptoms. So again, there may be more than, or it may not simply just be elevated pressures that are causing the patient's symptoms in this condition. So let's jump over to our differential diagnosis for vascular. We'll talk about popliteal artery entrapment syndrome and a little bit about arterial endofibrosis. There's some case studies of exertional deep vein thrombosis in the lower extremities. This is more related to thoracic outlet syndrome and Paget-Schroeder. It's pretty common to have exertional thromboses, but there are some case series in the lower extremity, but we won't get into those too much. But then you can see the differential over here of non-exertional things that we should think about that may be related to exertion, but are not a directly from exertion itself. So you can read through those on your own. We'll go to the next slide. So popliteal artery entrapment syndrome, entrapment or compression of the popliteal artery and sometimes the vein within that popliteal fossa. We don't really know what the prevalence of this condition is, and we think that it may be more common, or there may be more people at risk, but they might sort of self-select themselves out of sports. But of course, in our setting, in the military setting, these people don't really have the option to select themselves out. So it's something to think about, that people at risk in the military, it might be more common than we realize. There's functional and anatomic types that we'll go over here in just a second, but the functional type seems to be more common in athletes. And I would think that our population in the military probably falls into this athletic population a little bit, and more common in females. The anatomic seems to be more common in sedentary and male patients. So what are the symptoms of popliteal artery entrapment syndrome? This is kind of classic, the claudication, the heaviness, the pain, the aching deep in the leg with exertion. They'll sometimes get digital ischemia, and then tibial nerve paresthesia seem to be much more common with popliteal artery symptoms or syndrome. And then if the vein is involved, there may be some calf swelling along with it. And I thought, in case Dr. Buchanan was on, I felt obliged to throw a BYU picture in here. But this is Luke Staley, was an All-American running back at BYU, and he had the biggest calves I've ever seen when I was working with them. Just had amazing power in his calves, but he seemed to have a lot of lower leg issues. I won't get into for HIPAA reasons, but when you have a lot of muscle mass and very powerful muscles in there, I think people are at risk for some of these entrapments. And we see that in the military a lot too. So here are the different types of anatomics. So we have type 1, 2, 3, and 4. And you can see on the picture that it's various, either the course of the artery is a little bit anomalous, or the insertion of the medial head of the gastroc may be anomalous or have extra slips. And then in type 4, the popliteal vein becomes entrapped along with the artery around the popliteus muscle in the back of the knee. But then this type F is the functional type here at the bottom. And this is the people that have no anatomic abnormalities that we can see, but they get entrapment of the artery by the medial head of the gastroc or the soleus muscle. So how do we evaluate for popliteal artery syndrome? It's difficult. The ankle brachial index is a good test and not too difficult to perform. We'll send people to vascular surgery to have this done because they can do the other evaluations as well. But you want to do pre and post exertional ABIs. And if the post exertional is less than 0.66, this is highly suggestive. I think 80% sensitivity for that ABI number. If it's less than that, then they probably have some sort of entrapment, vascular entrapment. You can do angiography and Doppler ultrasound that will give you a good view of the artery and give you good information. But there's limited evaluation of the surrounding anatomy when you do this. If you're trained in ultrasound and you're able to do some of the other anatomy around there, that would be a good thing, a good skill to have. You can do ultrasound dynamically, and so you can have the patient do some exertion and really get a good look at it. But most of the radiology techs, like with vascular surgery, are just looking at the vessels. They're not looking at the muscles and the other surrounding tissue. So when you send someone out for this, it has limitations. MRA or CTA are good. They give you a good view of the surrounding anatomy, but they're hard to get dynamically. It's hard to do the timing, and it's really hard to get an exertion protocol where the patient can really exert and then get a real-time MR or CT that shows the vascular while they're having symptoms. So this can be difficult to evaluate, and you have to work with the radiologist to really protocol these and see what their capability is. This is a picture of, and supposedly these are all the same patients, but A has a linear probe, and then B and C are curvilinear, so I'm not sure what the difference is here, but you can see the popliteal artery looking at it in longitudinal, and this just shows patent flow through that artery. And then the middle picture is that same artery with the patient performing plantar flexion. So heavy isometric exertion holding a plantar flex position. You can see that the artery becomes occluded and there's less flow. And then this third picture is when the patient relaxes, you see an increase of flow, and called hyperemic response, where you get a lot of a rush of fluid through that artery, a rush of blood, excuse me. So if you can get the timing on this and get a good study, you can get really good information with this ultrasound. So for popliteal artery entrapment syndrome, maintain a high index of suspicion for this with patients with exertional leg pain. I would say call the MSK radiologist and discuss their protocol and see if they can do it. We've had patients that we sent for this and we protocoled it, and then when they showed up, it was just some tech who did the standard thing, and we didn't really get what we were looking for. So you want to coordinate if you have the suspicion for this with your radiologist to make sure they get the right study. And if they're willing to work with you, there's creative ways to do this. You know, you can have the techs work with you and have the patient really exert or hold an isometric plantar flexion contraction for, you know, a couple minutes and really try to get a good study. The treatment for this is surgical release of the medial head of the gastroc, or transposing the medial head of the gastroc to try and get it away from the artery. You might be able to do some activity modification or movement modification for the patient if they have poor mechanics or gait mechanics or something. And then there's some idea it's not really great literature on this yet, that Botox may be an option here too. If they just have hypertrophy of that medial head of the gastroc, so you can inject Botox in there and cause a little bit of atrophy, and maybe that will give the patient some relief. So this study came from the Mayo Clinic, and they have a protocol that they've used for a number of years to evaluate for chronic exertional compartment syndrome, where they put them in the MRI, and they have a special apparatus that they can use while the patient is in the machine, where they can do maximal plantar flexion and dorsiflexion and hold those positions for a couple minutes, and they time the study with the patient's exertion. And so they can use MRI to diagnose chronic exertional compartment syndrome based on typical MRI findings. So what they did is they went back and looked at a 10-year period of patients that had been diagnosed with this protocol, or diagnosed with CECS by this protocol. And they had 64 patients. And of those 64 patients, over 50% had some evidence of peripheral artery entrapment syndrome using this same protocol. And it's not something that's used. I couldn't find it being used anywhere really but the Mayo Clinic. So we can't really order this, but what they did show is that and of those 33 patients, excuse me, that had peripheral artery entrapment, there were no anatomic anomalies seen on the MRI. So all of them were a functional popliteal artery entrapment. And then 90.9% of the patients with a positive vascular study of some kind had more than one positive test for peripheral artery entrapment. So that was an ABI or a CTA, MRA, duplex ultrasound. So a high percentage of patients that seem to have entrapment along with chronic exertional compartment syndrome, and several studies confirming that there is some popliteal artery entrapment and that it's a functional thing. So these two probably travel together more than we realize. And this study just came out in 2020. So probably over the next few years, you'll see more of this coming out. Exertional iliac or external iliac artery endofibrosis. This is the most common subtype of arterial endofibrosis, intimal thickening from repetitive strain. It seems to be most common on the left. We don't know why, but this is common in athletes who spend a lot of their time exerting themselves while they're in hip flexion. So this is cyclists, some case studies in rowers, but the longer, the more hip flexion you have, so time trial cyclists, triathletes who spend a lot of time down in the drops with a lot of hip flexion, or the longer you're on the bike, the more at risk you are for this. This is some images of the ultrasound. You can see the normal on the upper left, patent artery with nice flow. And then on the upper right, you can see a lesion, that intimal thickening of the artery. And this is with the patient with the hip extended. And when they flex, you can see how that lesion there at the distal end of it, it forms a kink in the artery when they're hip flexed, which is going to decrease the flow through the artery beyond just having some obstruction from that lesion. So again, this is something that you would want to think about in cyclists especially, but anybody that's in a lot of hip flexion while exercising. I didn't really talk about the treatment for this too much, but the treatment is to either to stent the artery or modify their activity and have them not do so much hip flexion. But keep this on your differential for patients, especially if they're having some thigh claudication symptoms as well associated with the lower leg. And then let's just go briefly through the neurologic differential diagnosis. So nerve entrapment is the one that I'll spend the most time on. Keep these other things in your differential, but they're not necessarily exertional related. So these patients may have some pain at rest that increases with activity. There may be a history of trauma or history of surgery, use of supportive devices that's causing entrapment or compression of a peripheral nerve. And depending on the nerve, they may have associated weakness. So these are some common points of entrapment. This adductor canal just above the medial knee is a point of entrapment for the saphenous nerve. Points of entrapment around the knee and the lower leg for the common peroneal nerve and its branches, deep and superficial as they enter into those anterior and lateral compartments can get entrapped. The superficial peroneal nerve can get entrapped or compressed as it comes out of the crural fascia just above the lateral ankle. And then there are entrapment points for the deep peroneal nerve around the anterior ankle and the foot. So any of those areas can become a source of compression. The evaluation for this, just doing a neurologic exam, so a Tinel's type test directly over the point of entrapment may give you a positive test. You can get electrodiagnostic studies like nerve conduction study and EMG. They have a low sensitivity, especially early on. So the classic teaching is wait at least 3 weeks, 21 days from the injury to when you get a test. Most of our patients are probably going to have had symptoms long enough that they'll be, you could order these tests. A lot of what we do in the sports clinic, of course, diagnostic ultrasound. So looking at the nerve, looking for points of entrapment, looking for points of compression, maybe swelling proximal to the point of entrapment. You might see swelling around the nerve. And then we can block the nerves or do an ultrasound guided hydrodissection to try and open that up. And if they get improved symptoms, then that can be diagnostic for us. A lot of these are going to be movement retraining or modification, equipment modification. Don't lace your shoes so tight. Don't wear your knee brace so tight, you know, on the medial knee or other places that there might be some compression. Okay, let's circle back quickly to our cases here, and then we'll wrap up. So going back to our first case, the 17-year-old male athlete, a quick question here for any students or residents that might be on. So which of these physical exam findings suggests that this patient does not have chronic exertional compartment syndrome? So he has leg pain at a predictable activity level, a normal MRI, dorsiflexion, weakness while symptomatic. That could all go along with CECS. But this patient actually did have a post-exertion ABI of 0.6. That's the right answer. The positive ABI suggests that this is maybe not CECS and something else. And this patient actually ended up having functional popliteal artery entrapment syndrome. So we were able to show that on ultrasound. We got him symptomatic, had him plantar flex, and he had some compression of the artery by the medial head of the gastroc. He actually had a long enough course of evaluation with all the studies and then relative rest while he was waiting, and COVID and some other things happened that it just resolved. So maybe he just sort of outgrew it. You know, the medial head of the gastroc had a little atrophy while he was resting. Maybe he changed his gait, but his symptoms just ended up taking care of themselves, and he was able to get back to pretty normal activity without symptoms last time I saw him. The second case, this 17-year-old female athlete with right greater than left pain. So the question for her is, which finding is the most specific for our diagnosis? And I hope you're all thinking that this is some kind of bone stress injury. Focal bony tenderness to palpation at the right anterior tibia, or tenderness to palpation along the medial distal third of the left tibia, the progressive pain course, or a two-sport athlete. So the most specific for her would be the focal bony tenderness at the right anterior tibia. So I think she actually had, we got an MRI, had some T2 signal that showed periosteal and some marrow signal at the right tibia, right at the point where she was tender. So she had a bone stress injury. On the left, she had some posterior tibialis signal on the MRI, kind of non-specific. And she as well, we had her stop activity, took her several weeks to get an MRI. And by the time all of the evaluation and follow-up was complete, her symptoms had mostly resolved. So I think she had medial tibial stress syndrome on the left, and she had a tibial bone stress injury on the right. Our third patient, the Army Infantry guy. So the question for him is, what pressure is considered positive for chronic exertional compartment syndrome? A pre-exercise stress of 30, or pressure of 30, 1 minute post-exercise of 70, 5 minute post-exercise of 30, or a 5 minute post-exercise of 15. This is a trick question. So these are his numbers. A, B, and C are all diagnostic. D is not. So this guy actually was diagnosed with CECS while he was deployed, and those were the pressures. He had 30 plus, 70 plus, and 30 plus pressures measured while he was deployed. So diagnostic, they sent him back to the States. He had fasciotomy, and this was several years ago. He did okay for a little while, but when he started getting back to his duties, so rucking and other things, his symptoms came back. So he was referred to sports medicine to do compartment testing prior to a repeat fasciotomy. He didn't really want to get surgery, so we tried a couple things. We tried Botox injection with him. After about a month, he wasn't really noticing any improvement. He continued to have some signs and symptoms of exertional compartment syndrome, including when we did his reevaluation, he continued to have elevated pressures and weakness in dorsiflexion. And then our last patient, the 26-year-old female. So the question for her is, which peripheral nerve gives sensation to the dorsum of the foot? Deep peroneal, superficial peroneal, tibial, or the sural nerve? And the answer for that is B, the superficial peroneal nerve. So with this patient, she was not having a lot of weakness, just paresthesias on the lateral leg and the dorsum of the foot. So we brought her in and did a gait analysis with her, and her gait was actually great. She ran really well, and she was able to run for a while without any weakness, no foot drop, but she started to develop lateral leg paresthesia and dorsal of the foot paresthesia. This is also a patient who had actually had a fasciotomy in the past. And I'm not sure whether that was the right diagnosis for her, because she never had the compartment pressure testing. This was all based on history and physical exam. So we did an ultrasound of the superficial peroneal nerve, especially on the left, which is the more symptomatic for her. And where they had done the release, the nerve ran right through the scar, and it had variable caliber. So there's multiple entrapment points of the nerve. And we have done for her 1 round of hydrodissection along that nerve, and she had a partial response. So she had improved symptoms, but not complete relief. So we're going to try a few more rounds with her and see if we can open that up. But I think in this case, she was a peripheral nerve entrapment, maybe from the beginning. I don't know for sure, but this may have never been chronic exertional compartment syndrome. So, and I know you can't see this. This is from one of the articles that I referenced at the end, and I think it's a good article. And this is an algorithm for how they break down the evaluation. But all I really want to point out from this is that if you look at the end points for each line of the algorithm, there's a lot of crossover. So whether they have symptoms at rest, maybe it's exertion, maybe it's a peripheral artery entrapment syndrome, but peripheral artery entrapment also shows up over here in these other areas that don't involve symptoms at rest. So just keep your differential broad. There's not definite symptoms that will lead you to only one thing. So in reality, a lot of cases, or maybe most cases of exertional leg pain are probably maybe multi-system. It may not just be one thing going on. So don't narrow your differential too soon. So this is common. You'll see it. Use a systematic approach. Keep your differential broad. And I would say don't be too quick to send patients with chronic exertional compartment syndrome to surgery, even if their pressures are elevated. This is not acute compartment syndrome. It's not something that needs to be treated urgently. This may be a multi-system etiology, and there may be other options to treat this that won't involve having to have fasciotomy. The fasciotomies are successful in the general population, but the military data suggests that probably half at best of patients that have had a fasciotomy will get back to their previous duty, and a lot of them will end up being med boarded out of the military. So try some other things first if you're not completely convinced that fasciotomy is going to work for them. But with that, I will finish it up and open it up to questions. And I know Dr. Leggett's monitoring some of those for me. So first question is, why do people do this to themselves? I think this is unnecessary to have that kind of muscle mass, and just being functional is probably better than being big and bulky like this guy. But I will go to my references and then any questions.
Hey, Dr. Maloy, there was a few different comments on, well, first off, that was a great job. Thank you very much. And I learned a few things. I won't tell you what I didn't know before, but we'll leave it at that. So there were some comments on gait retraining, and we're lucky to have Dr. Velasco here. She's a physical therapist, certified in sports medicine ortho. And so what we talked about, or one of the questions was, can any physical therapist do gait retraining? And the answer is kind of, sort of, is what we gave to them. And it depends if you're going to do formal gait analysis, and then everybody comes from different schools, and what are you going to actually retrain? And then also, what do they retain? And so one of the easier things to do is actually just change your cadence. And if you increase your cadence, that makes your run softer. That's kind of what we put up there. And then one of the other questions was, should we do gait retraining for everybody when they get in the military? Same loaded question, because it's probably not a blanket answer for everybody. So how would you answer that, Dr. Maloy?
I didn't hear the very last part of that second question.
So the second question, is there any utility to doing some gait retraining for everybody while they enter basic training to try to avoid some bone stress injury? Over.
I wonder if Dr. Nye is on here with us. You know, maybe, but that's very labor intensive. And there's, you know, why, if somebody's not having symptoms and they're running and they're doing just fine, we don't necessarily have to intervene in the hopes of preventing something down the road. Everything that I talked about, while it's common, it's still not the rule. You know, most people are going to do just fine. So I don't think that would be a good use of resources beyond maybe just, you know, talking a little bit about just general gait mechanics or running biomechanics with people. But it would be very difficult to do, and I'm not sure it would be the juice would worth the squeeze on that one.
And then, Wyatt, how would you answer the question about sending someone for gait retraining? How do you pick which physical therapist you send them to? Over.
Oh, so this is hard. You'd want to talk to your therapist and see, you know, how comfortable they are and what their training is in it. Like Dr. Velasco had said that not all therapists are going to know how to do gait retraining, and there's a lot of approaches. So, you know, I would try wherever you're at, talk to a few therapists and see who among them are comfortable and knowledgeable, and how they would do it. I know there are a lot of physical therapists who will just sort of, you know, have sort of a blanket gait training program that they'll go through, and a one size sort of fits all. And I don't think that that's a good way to go. So you'd want to look for someone who is comfortable doing the gait analysis, who's comfortable, you know, doing like the video analysis at a minimum. Some places will do, you know, force plates and you know, measure foot strike, pressures and all kinds of things, and vertical ground reaction forces. But I would say at a minimum, someone who's comfortable putting a patient on a treadmill or taking them out and running and watching their running biomechanics and doing customized interventions, including things like Dr. Leggett had just talked about, helping them increase their cadence, increase their hip extension, their push off with their hips. Yeah, those kind of things. But just making sure that it's not just a one-size-fits-all approach by the physical therapist, and that they're comfortable doing the full gait analysis.
Let me get the last question, a couple of comments too. So when we talk about doing gait analysis, there are a variety of ways to do that. In one lab is not the same as another lab. Usually they put someone on a treadmill, and that is not what you actually do in real life. There's only a few places that actually go out to the field and do true gait analysis. And so be wary what you get. The last question before we end is from Dr. Harris, and her question was, what's the current data regarding types of shoes and injury prevention and shoe life recommendations? And I told her that there wasn't great data. In fact, there's been a pretty good study that came out and said what your natural running stance is your natural running stance, and it's a little bit of a trial and error for shoes. What works best for you is probably what works best for you, and all we can do is general recommendations. That said, if you are running a fair amount, which would be 20 miles or more a week, you probably need to change your shoes at a minimum every year. Is some general recommendations. Wyatt, how would you answer that as a final question?
Yeah, I don't disagree with anything you said. We're actually, stay tuned. We're working on an article right now to kind of go through the most recent literature and publish. So probably next year in current sports medicine reports, we'll put an article out involving shoes. Yeah, there's not great evidence. My general recommendation, or what I tell patients when we talk about this, is that the shoes are most important for how they affect your gait and your biomechanics. You could probably run in just about anything if you ran with a good form. And so that's more important than what shoes you wear. So wearing comfortable shoes, my personal bias is tend toward less is more, not necessarily barefoot or minimal shoes for everybody. But if you start adding a lot of extra control in, I think it tends to make people run poorly more than it helps them control, pronation or anything else. So that's my general bias, but it's hard to get good evidence for that, and we're working on it. There's a lot of things that are out. When I say we, I mean in general, medicine is working on it, but we don't have great evidence one way or the other yet.
Well, with that, we're right at 1300, and so Dr. Maloy, I think this has been a great job, and I really appreciate you bringing this to light. I would say if you have some other questions, feel free to send it to Dr. Maloy and myself, and we'll do our best to answer that. And with that, I hope